Sir, we can't hear you, sir.
Am I audible now?
Yes, sir, you are.
Okay. So good afternoon, everybody. Uh, Today we are going to talk about WHO step 3, um, and this will be mainly concentrated on strong opioids. And thus, I want to make it as an interactive session. So when this is mainly case-based sessions. So whenever there are questions, I request you to please try to answer those questions so that we can go forward. Okay. So I will start sharing the screen. Rajlashmi,
Yes, sir, you can.
please make me co-host.
You are, sir. You can share the screen.
I hope it is visible.
Yes, sir, we can see it.
Rajlashmi, okay. So, what I am going to
Sunil, sir.
mainly I am going to talk on action of opioids, and there will be many doubts regarding the use of opioids. So this we will talk from a practical point of view and the side effects of opioids. Uh, So all of you know that this is the WHO analgesic ladder, which has 3 steps. And from the second step onwards, we have opioids. The second step has weak opioids, whereas third step has strong opioids, or in otherwise it is known as opioids for moderate to severe pain. So all of you can see this photo of a patient. So what is the main problem this patient is suffering from? Anybody can unmute and speak.
Maybe some oropharyngeal lesions.
Sorry.
Maybe some oropharyngeal lesion causing severe pain.
Okay, thank you. So suppose this patient comes to you and you see him in such situation. What will be your main concern?
Take care of the pain.
Yeah, thank you, sir. So you can see his face, and which tells he is suffering from severe pain. So this patient, 56-year-old man with the carcinoma of the larynx, he came to us in the morning, and the main problem was pain, severe pain. That was 10 by 10, and there was no radiation of pain. And he was unable to sleep because of this pain for the last 2 weeks. So, uh,
Dr. Sunil. Sir, we can't see the presentation.
okay, I will share it again.
So can you repeat what you said last also? We are not able to hear you.
Okay. So, how can we manage this patient? Suppose this patient comes to you. How are you going to manage him?
find out if he's already on some drugs for pain relief, because most of the times patients do take some drugs by themselves, or somebody must have prescribed some NSAIDs or other things. So we'll find
Yeah.
out what he's already taking,
And then?
and then we can think about going to the next stage. No, we can think of giving him an opioid injectable, probably if it is very severe pain, and we can start with a loading dose of opioid.
Okay. Dr. Parul, do you want to say anything?
Dr. Parul, can you unmute from your end and speak?
Yeah, yeah. Good afternoon, all. Yeah, so as the previous madam mentioned, that we will find out what drugs he is on. So we have a baseline thing of what he was already taking. And then since it is clear from the history that, the pain score is 10 by 10, that means it is a severe pain. So we need to give him opioids. Now, whether intravenous or oral, we have to decide. So if it is a hospital setting, intravenous is possible. But if it is like a home-based setting or something, we can consider giving him oral morphine. So oral morphine, with my prior experience, what we used to do is the IV morphine trial to titrate the dose of morphine. So we used to titrate, like if it's a 15 mg vial, we used to dilute it, 10 mg, 10 cc syringe as 1.5 mg per ml, and we used to give like 1 ml. Okay, so till the patient develops respiratory depression or becomes drowsy, or there is a complete pain relief. So say in 3 ml the patient develops complete pain relief. That is 4.5 mg. So the next dose is 5 mg. So we can put him on a dose of 5 mg morphine every fourth hourly regular, along with a laxative and adjuvant other analgesics like a regular paracetamol, oral or IV, depending on the setting, and NSAID. So this would be my plan of management.
Okay. Thank you, Parul.
Yeah.
So how frequently would you give injectable morphine? 1.5 milligram?
See, like every 5 to 10 minutes, we would wait at least for 5 minutes.
Okay.
Yeah.
Yeah. Thank you.
We need to have patience. We have to give it really slowly to assess the response.
Yeah.
Yeah.
So, so you can see this patient, Rajlakshmi, there is a lot of disturbance.
I request all to stay muted. So you can continue, sir.
Okay, so you can see this patient after some 30 or 45 minutes, he is able to smile. And as Dr. Parul told, we also gave intravenous morphine trial, which is otherwise known as intravenous morphine titration. So this is a rapid technique for pain relief, and there are many methods for rapid titration of morphine, and which we use, and what Dr. Parul told is something which we developed when we were in Calicut. Okay. What we do is we give injection morphine 1.5 milligram at 10 minutes interval. So the available vial in Kerala is 15 milligram, which contain 1 ml. So we will dilute this vial with 9 ml of normal saline. So total 10 ml, which contains 15 milligram of morphine, and each 1 ml contains 1.5 milligram of morphine. So you give injection morphine 1.5 milligram at every 10 minutes interval. And what is the immediate side effect that you are expecting by administering the first dose morphine? Anybody?
Nausea?
Yeah, exactly. So
Shortness of
some
breath.
patients can have it's mainly it's nausea and vomiting. So about 1/3 of the patient can have vomiting. So we have to give an antiemetic. So usually we give injection metoclopramide 10 milligram IV, followed by injection morphine 1.5 milligram every 10 minutes interval. And what is the endpoint? either satisfactory pain relief or sleepiness, whichever occurs first. So all the pains are not opioid sensitive. So in such patients, even if you give morphine, sometimes the patient will become drowsy and there will not be satisfactory pain relief. But you have to stop it there if the sleepiness is the first thing which is going to occur. Okay. So this is the intravenous morphine trial or intravenous morphine titration. So you can give rapid pain relief for the patient. So for IV morphine trial, you can have this a table with the time, pulse rate, respiratory rate, blood pressure, pain score, is the patient drowsy or not, and what is the injection dose of injection morphine. So you can see this patient came at 10 o'clock. Pulse rate, respiratory rate, blood pressure all recorded, and the patient pain score is 10, and patient is not drowsy. Then you will give 1.5 milligram. Then at 10:10 a.m. you will reassess the patient, and again you will record all the vitals. Then you will ask the pain score. It's 7 now, and patient is not drowsy. You will give again 1.5. So this patient you can see with 3 doses of morphine, the pain score came down to 1, and patient is not drowsy. So you will stop the trial. So this patient received total 4.5 milligram. So how will you convert, is this an inpatient procedure or outpatient procedure?
Inpatient, sir. We have Dr. Namrata saying inpatient.
Inpatient. It's inpatient.
Inpatient.
It is impatient,
Okay,
sir.
Dr. Parul, what do you usually do? Sorry, you are muted, Parul.
Yeah, but I did not get your. Is your question whether we'll go for the oral or the IV route?
No, I am asking whether this IV morphine titration, is it an inpatient procedure or outpatient procedure?
Okay. Now, if you ask my personal experience long back, we were doing as an outpatient because this we are using this procedure for pain relief and for quantifying the dose of oral morphine which can be given to the patient, which he can take very comfortably at his home setting. Yeah.
Thank you. So this is not an inpatient procedure. You can do it as an outpatient procedure, and we at least have 2 or 3 morphine trials per day, injection morphine trial. So it's an outpatient procedure. And how will you convert this 4.5 milligram of IV morphine to oral morphine? Because we need to discharge the patient to go home. So how will you convert?
Multiply by 3.
Okay. Anybody else?
I think everyone can.
Yeah. Now, what
Dr. Parul, you can continue.
Yeah. The thing is, what we used to do is the IV morphine dosage, which caused a complete pain relief, was 4.5 mg. So the nearest oral morphine tablet which is available is 5 mg. Now, the dosage of oral morphine is given regular every 4 hourly. So in that case, our prescription would be 5 mg of morphine every 4 hours.
Yeah, thank you, Dr. Parul. What you have told is correct. So you can convert this 4.5 milligram to the possible nearest oral tablet of morphine. So 10 milligram of morphine is available as tablet. So you can convert it into 5 milligram. You can break the 10 milligram tablet into 2 halves, and 5 milligram can be administered every 4 hourly. So this is how you administer morphine. So for this patient, tab morphine 10 milligram. When the patient wakes up, you will administer half, followed by 10 a.m., 2 p.m., 6 p.m. At bedtime, usually double dose is given, and you can also give half as an SOS dose if the patient has severe pain. So this is how you give morphine tablet. It's every 4 hourly, and you can note that at bedtime you give the double dose. Uh, and there is a reason, and you can find out what is the reason why it is given double dose at the night. Okay. So if I know that many of the centers, palliative care centers, will not have injectable morphine, and in such situation you have to give oral morphine trial if this patient comes to you. So if the patient is opioid naive, that is, if the patient is not on any opioids at present, then you can start with 5 milligram of oral morphine. Or if the patient is on weak opioids like tramadol or codeine, then you can give 10 milligram. And this is how you will do oral morphine trial. So in opioid naive patients, start with 5 milligram, and in opioid patients who are already exposed to opioids, you can start with 10 milligram of morphine. So our patient was started on 5 milligram morphine 4 hourly and SOS. He was relatively pain-free for 2 weeks, but then he required 4 SOS dose per day for the last 4 days. So what shall we do now?
Yeah. Shall I?
Yes, yes.
Since the patient is requiring a lot of breakthrough doses of morphine, it means that the dose of morphine that we are giving is probably not enough. So this is the time when we should consider escalating the dose of morphine. So we can go to 10
Yeah.
mg every 4th hourly and SOS every.
Okay. Uh, so this patient is getting 4 SOS dose, and as Dr. Parul told, the present regular dose is not enough. That's what SOS dose indicates. So you can increase the dose of morphine. So how much you will increase? And increase 30 to 50 percentage. And the indication to increase the dose of morphine is if the patient is taking 2 or more than 2 SOS dose. Rajlakshmi, can you mute everybody?
Yes, sir, you can continue.
Yeah. If the patient is taking 2 or more than 2 SOS dose, PRN is same as SOS dose, and you can increase it by 30 to 50 percentage. And actually, you can increase the dose of morphine every 24 hour. Okay, not 2 to 3 days. You can increase every 24 hour. Every day you can increase the dose of morphine. So if you increase 50 percentage of the dose, 5 milligram was the what a patient was getting, so you can increase it by 50 percentage. That means 5 into 5, that is 2.5. So from 5 to 7.5. And if you go to 10 milligram, it is 100% increase. But in this patient it should be okay. But it is always good to start with a lower dose. Then not side effects, toxic effects, then the patient will hesitate to take opioids. So maybe 7.5, it may be difficult to make it quarter tablets, but still it is good to try whether the patient can take 7.5 milligram. So we told that in addition to regular dose, we can give SOS dose of morphine. So suppose the patient's is taking oral morphine tablet. How frequently would you give SOS dose of morphine?
After 2 hours, Dr. Kanagasabha says,
Okay. Anybody else? Okay. Uh, so let's see how frequently we can give. So we need to see the pharmacology of morphine little bit. I see there is some response, Rajashmi.
Till the pain subsides, Dr. Gopal says.
Okay, so you can see this is poppy plant. The scientific name is Papaver somniferum, and this is grown in legally only in 3 states of India. That is UP, MP, and Rajasthan. Only they can grow legally morphine plant or poppy plant. Okay, this you can see the seed which is known as pod, and the farmers will make cuts on this pod, and you can see the sap is coming out. The sap is collected, dried in sunlight, and then it is transported to government opium and alkaloid factories, where they will make morphine powder out of it. So from which part of the plant you will get morphine? Which part is used to produce morphine?
Is it the seeds? From the seeds?
Seed. Okay. Anybody else?
Seed capsule.
Okay.
Unripe seed capsule. That is what Dr. Kanagasabha says.
Okay. So actually, all the parts of can be used for morphine, for producing morphine powder. The International Narcotic Control Bureau, that is INCB, they decides for each country from which part of the plant they can produce morphine. And I think India is the only country which can produce morphine from the pod, and which is the most abundant source of morphine. Actually, stem, leaf, root, all those can be used to produce morphine. But INCB decide from which part of the plant you can produce morphine. Okay. So we will talk a little bit about pharmacokinetics. So morphine is a weak base, and it is absorbed from the upper part of small intestine. And morphine is hydrophilic. That means it is water soluble. So it has, because of this hydrophilic nature, it has a slow onset of action. But because of the same property, it has longer duration of action. Yes. Okay. So after absorption, okay. So these are something which we have to understand correctly, because there will be various people talking about these routes of administration. Uh, so many people use sublingual morphine, but research indicates that sublingual absorption is very low. And if the patient has pain relief after sublingual absorption, that means that patient has swallowed it, and that's why the patient has proper pain relief, not because of the sublingual absorption. And buccal and gingival route also should not be used for morphine administration. And if you give morphine as powdered, because patient is unable to take, and if you want to powder the morphine tablet, then you have to sweeten it with something, because it has a bitter taste. And this is what happens when you administer orally. It will go into the gastrointestinal tract, and from the gastrointestinal tract, which will be absorbed into the blood vessels of the intestine, and then goes into the portal vein, and from the portal vein to liver, where metabolism takes place. And uh, the metabolites are liberated into the systemic circulation. So main metabolites and metabolism actually mainly takes place in liver, but a minor part also takes part in gastrointestinal tract as well as in kidney. And 90% of morphine is converted into metabolites, and 10% bypasses liver. And the main metabolites are morphine 3 glucuronide and morphine 6 glucuronide. You can see morphine 6 glucuronide, that is M6G. It is formed 5 to 10%, and that's the active metabolite which will give you the pain relief. M3G doesn't have much action in our body. Okay. So from this, we understood that morphine has to be swallowed orally, it has to be absorbed, it has to be metabolized in the liver, and then liberated into the systemic circulation for action. So this will, the pain relief may start by 30 to 40 minutes, but the peak action will be by 1 hour. So we have to wait for at least 1 hour for administering SOS dose, because that is the time where the morphine will have peak action. Okay. So our patient's morphine dosage was increased to 10 milligram 4 hourly. But he says, I am unable to take it every 4 hourly. I am taking too much of tablets. And if you give it less frequently, I am willing to take it. Do you have any option?
Sir, SR morphine.
Yeah. Yeah, we can give sustained release morphine. Okay, so sustained release morphine or slow release morphine. So the duration of action of sustained release morphine is 12 hours. So that this patient total dose of morphine per day is 60 milligram. So you can give morphine tablet SR BD. So the problem is this is costly compared to the immediate release tablet morphine. So these are the preparations of morphine available. Syrup morphine is available. Tablets, as I told you, two types: immediate release and controlled release. Immediate release tablet have 4 hours of duration of action, whereas controlled release have 12 hours of duration of action. And injection is also available. In Kerala, it is 15 milligram per 1 ml, but it will be different for different states. Okay, so our patient is still on 10 milligram of morphine, and he was good with pain was very well controlled with 10 milligram morphine every 4 hourly. But one day when you were taking casualty duty, this patient was brought to you with excessive drowsiness, and on examination, it was found that his serum creatinine is elevated to milligrams per deciliter. Will you do anything with morphine dosage now?
Yes, decrease it. Stop it
Decrease.
initially and then decrease it.
Yeah. Why should you decrease the dose of morphine?
Because the creatinine clearance is low now, and the morphine 3-glucuronide will not be excreted.
And also
So
patient
higher
is
dose
having,
will be available.
also he is having excessive drowsiness. The idea of pain relief is to take that edge off the pain and make him comfortable, but at the same time ensuring that he is alert enough to interact with the family or other people.
Okay. Thank you, Dr. Mahalakshmi.
So Dr. Namrata also comments like increase the duration in between doses.
Okay. Thank you. All of you are correct. So the excessive drowsiness can also be a sign of morphine toxicity. As Dr. told, when the morphine is excreted from the body by glomerular filtration. So when there is poor renal function, the morphine which is metabolized in your body will be circulating in your blood, and the morphine 6-glucuronide which will be there, and which is the main or active component which will give you pain relief, will be there in the blood, which is not excreted. So that it can cause excessive drowsiness, it can cause delirium, it can cause myoclonus. So we have to actually reduce the dose of morphine. this is the situation where you can increase the spacing. That is, instead of 4 hourly, you can administer morphine either 6 hourly, 8 hourly, 12 hourly, or there will be certain situation when the serum creatinine is very high and the patient is undergoing dialysis. Sometimes you only need to give once daily dosage. Okay. Or you can use renally safe opioids like fentanyl, methadone, or buprenorphine, which are renally safe opioids. So we have to reduce the dose of morphine as well as increase the spacing. So we reduced the dose of morphine to 5 milligram 8 hourly. After 2 months, he was unable to swallow anything, including morphine. So what will you do now? Patient is at home.
Dr. Namrata says about patches.
Okay. Dr. Namrata, what patches?
Fentanyl patch.
Okay. Fentanyl patch. Okay. Anything else?
Buprenorphine.
Okay.
Usage of PEG tube.
Patches. Usage of
PEG tube. RT tube. RT tube.
okay. Yeah, understand. Okay. You know that buprenorphine patch or fentanyl patch, these are very costly, and buprenorphine is comparatively costlier than fentanyl patch. Uh, how can we give him morphine itself and not any other medications? Okay, so you have to understand what are the routes through which you can give morphine. So we know that intravenously or subcutaneously we can administer, orally we can give. And what are the routes? What are the routes through which you can give morphine? Yeah, so per rectally, then epidural, intrathecal. So this patient is at home. So you can actually administer morphine per rectally, but some patients may find it difficult, but practically this is possible, and we are doing this per rectally. Morphine is given per rectally. So for this patient, we can administer the same dose of morphine, 5 milligram 8 hourly through per rectal route. So whatever you are giving orally, the same dose, same action through rectal route. So both routes are almost comparable. So this patient's pain can be relieved by parectal administration of morphine. You can use immediate release tablet. And as I told you previously, so you can take 2 drops of water and make a paste with morphine and rub it over the rectal mucosa. So the patient will have good pain relief. So we are leaving our the previous patient X, and now we are coming to patient Mrs. K. Mrs. K, 55-year-old lady with carcinoma of the colon, has abdominal pain, which is continuous in nature, and she is on 10 milligram of morphine 4 hourly, and she doesn't require any SOS dose of morphine. That means this patient's pain is stabilized. Okay, so if the patient doesn't have any ups and downs in pain, which is known as stabilized pain. So this patient doesn't require any SOS tablet. And because of stabilized pain, the treating doctor asked them to place 25 microgram patch, and so that patient can avoid taking orally.
Dr. Sunil, your voice is low, sir.
Okay. The next day, the patient is reporting to you telling that they replace fentanyl patch after 5 hours as she had no pain relief. What will you do now?
Basically, we need to give her a loading dose.
Okay. How will you give loading dose?
IM or oral also, I don't know. IM?
Okay. Anybody else who's experienced with fentanyl patch?
It takes 12 hours to take effect, at least 12 to 24 hours. So it should be overlapped with morphine, continued with morphine and then switched over to fentanyl.
Okay. Thank you, madam. So that's what you have to understand. The fentanyl patch, once you apply, it will take about 8 to 12 hours to produce a subcutaneous tissue depot. And after this 8 to 12 hours, fentanyl will be liberated in the circulation. That's what happens. And fentanyl is actually 100 times, 100 to 150 times more potent than morphine. The preparations available are injections are available, transdermal fentanyl patch is available, oral transmucosal fentanyl citrate OTFC, which was previously available. It is like a lollipop. Compared to morphine, fentanyl is lipophilic, morphine is hydrophilic. So these are some points which you have to remember while you apply fentanyl patch. First, it forms a subcutaneous tissue depot, and after this, it will take 8 to 12 hours, and after this, the fentanyl will be liberated into the systemic circulation. If you note that the dose of fentanyl patch is a micrograms, so 25 microgram, 50 microgram, 12.5 microgram, all this indicates the dose of fentanyl which is liberated into the circulation every hour. So 25 microgram patch means 25 microgram will be liberated every hourly. And the duration of action of this patch is for 3 days. So once you apply, 3 days patient can have good pain relief. And when you apply, you should not shave the area, because if there is abrasion, that is going to increase the absorption of the fentanyl, and temperature is also going to increase the absorption. So it is not suitable for patients with unstable pain. So patients whose pain has pain goes up and down very frequently, many times per day, this is not suitable, because the dose of fentanyl liberated into the circulation is constant. So this is suitable only for patients whose pain is stabilized. Okay. Now we will move on to another patient. Mr. H, 70-year-old man with carcinoma of the lung, has neuropathic pain of right upper limb due to nerve infiltration. He is on morphine 10 milligram Q4 hourly, tab amitriptyline 75 milligram, and pigabalin 150 milligram BD. He attends your clinic with delirium and myoclonus and doesn't have satisfactory pain relief. How will you manage this patient? So this patient has a neuropathic pain, which they have tried to control with morphine, amitriptyline, and pregabalin, and all of them. You can see that tricyclic antidepressant amitriptyline is optimized. The dose of pregabalin is also optimized, and the patient has delirium and myoclonus. How are you going to manage this patient? Anybody?
Increase the dose of morphine.
Okay. Anybody else?
He already has delirium and myoclonus, no? Like this delirium can be
Yeah.
ascribed to the side effects. All this can be ascribed to the side effects of drugs he has been taking. Maybe we can consider
Yeah.
block of the cervical ganglion or.
Okay.
So we can
Thank
think
you.
of some surgical or not surgical, at least image guided destruction of the ganglion so that he can get little better pain relief.
Yeah, yeah. Stellate ganglion block. Yeah. Thank you. Rajlashmi, I can see some response in the chat.
So Dr. Kevin says for myoclonus and delirium, dose reduction and haloperidol. Dr. Gopal says try invasive methods like blocks.
Okay.
Dr.
Yeah.
Bhargavi also says about blocks.
Okay, thank you all. So this patient has delirium and myoclonus, probably because of morphine, which indicates the toxicity of morphine, which is worsened by amitriptyline. So that means we will not be able to increase the dose of morphine. So what else can we do? All of you are in agreement with invasive pain management, but how many of you will get the help of an anesthetist to do stellate ganglion block? I am not sure because there will be many patients. Can we do anything else other than invasive pain management for this patient? Okay, so this patient is a suitable patient where we can use methadone. So methadone is a newer strong opioid which is introduced into Indian market in 2018. And you can see this is a isomer of S methadone as well as R methadone, and it acts on all opioid receptors mu, kappa, and delta. So these are the opioid receptors, and opioids acts on opioid receptors to produce pain relief. Methadone acts on all the three opioid receptors as agonist, and in addition it has an NMDA antagonist property. So NMDA is N-methyl D-aspartate. NMDA receptor is something which is involved in central when the pain is central pain. Okay, so serotonin, and it also acts like tricyclic antidepressant so that it inhibits the reuptake of noradrenaline and serotonin. So it has the property of amitriptyline. It has property of ketamine. It has a property of opioids. So it has three properties which makes it a different opioid. But it also has another problem. It blocks the HERG gene, that is human either go-go related gene, which is abundantly present in myocardium. And when this is inhibited, it can cause QT interval prolongation, and it can lead to torsade points and sudden death. Little bit about methadone. The important thing is that when you administer methadone, first it will appear in the blood, but rapidly it will go into the tissue binding sites. And once the tissue binding sites are filled, then only it will be liberated into the systemic circulation for action. So it is said that it will take about 5 to 7 days to this happen. So the action of methadone, it will take about 5 to 7 days. This is for getting full action of methadone. So in case of morphine, you can increase the dose every 24 hours. Whereas in methadone, the most important thing is you should not increase the dose of methadone till 5 to 7 days. And it is excreted through bowel. So in case of renal failure, this is a safe alternative. And if you want to know more about methadone, IJP's Indian Journal of Palliative Care has a supplement which came in January 2018. This is only about methadone. There are about, I think, about 10 articles on methadone. And this is another paper which you can refer, Safe and Appropriate Use of Methadone in Hospice and Palliative Care, Expert Consensus White Paper, which is also very good paper. Okay, so what if the patient is opioid naive, that is patient is not taking any opioid, and if the patient has moderate to severe pain, then you can use 2 to 7.5 milligram of oral methadone per day. If the patient is already on opioid, then this is the dose. If the patient is taking less than 60 milligram of morphine per day, start with 2 to 7.5 milligram. 60 to 199, and if the patient is less than 65-year-old, 10 is 1. So suppose this patient is taking 100 milligram of morphine. When you convert to methadone, you have to divide it by 10. So 100 milligram by 10. So 10 milligram of methadone has to be used every day. So maybe 5 milligram BD can be used. And if the patient is taking more than 200 milligram of morphine, then the conversion ratio is 20:1. So this is very important. Otherwise, you will start using more methadone, and more of problems methadone can occur. So these are the indications for methadone. Opioid neurotoxicity. So we saw that this patient has delirium, myoclonus, etc. So which indicates opioid neurotoxicity. So if any patient has opioid neurotoxicity, you can start on methadone. And if the patient has opioid tolerance or hyperalgesia, then uncontrolled neuropathic pain, patients with renal failure, and patients who has true allergy to morphine, all these are indications for methadone. So in selected patients, methadone can be very helpful. But some of the things which you should be careful is methadone has many drug interactions. Certain medications, it increases the dose of methadone, and certain can decrease the dose of methadone. And most importantly, you should not increase the dose of methadone till 5 to 7 days, and that's the time required for a proper stabilization of methadone levels in blood. So this is methadone tablet and syrup, which is produced only by one pharmaceutical company in India. So it is Armeth. That trade name is Armeth. This is available as 5 milligram tablets, and syrup 1 ml contains 5 milligram. So we will leave methadone there, and we'll move on to another patient story. Mr. P, 70-year-old man, has carcinoma of the lung and is complaining of throbbing pain on right front of chest, continuous 5/10. He is a non-epileptic and is on phenytoin 100 milligram BD. How will you manage his pain? Anybody?
Give him sodium valproate.
Okay. Anybody else?
Start with anti-epileptics.
Start with
Anti-epileptics. Epileptics.
anti-epileptics. Yeah. So he's already on phenytoin.
Gabapentin.
Okay. According to the WHO analgesic ladder, which step of the ladder would you choose to manage his pain?
Second step, sir.
Second step.
Yes,
So
sir.
this is a pain score. The pain score is 5/10. Select second step. So in the second step, it is opioids for mild to moderate pain, plus or minus non-opioid, plus or minus adjuvants. So what opioid would you select from that step?
Methadone, sir.
Tramadol.
Methadone comes in third step, sir. Methadone is a strong opioid. It comes in third step. So somebody told tramadol. What is the tramadol? Tramadol can reduce the seizure threshold. So, in a patient who is known to be epileptic, or if they are taking any medication which reduces the seizure threshold, sometimes tramadol can precipitate a seizure. So you should be careful. So tramadol is not a good choice here, but if there is nothing available, you can use codeine, then tapentadol, and another drug which is banned previously, dextropropoxamine, has come back into the market now with an indication to treat cancer pain. All this can be used, but not tramadol. Okay, and even low dose morphine can be used. So this is another patient, Mrs. P, on tablet morphine 50 milligram 4 hourly. She attends your clinic with severe pain. You have injection pentazocine and oral morphine tablet. How will you manage?
Oral tablets, morphine tablet.
Oral tablet. Okay, thank you. Anybody else?
Dr. Namrata says injection.
No, injection should not be used.
Pentazocine?
Contraindicated, sir.
Why injection should not be given?
Dr. Kanagasabai, why injection cannot be
I
given?
forgot the answer.
Yeah. Sarah's thinking. Okay, so for this, we have to understand a little bit about opioid pharmacology. Okay, all of you know what is an opioid. The drug to become an opioid should have two properties. One is that it should produce the action by combining with opioid receptors, and the second is its action should be antagonized by naloxone. Okay, and the receptors which we already told is mu, kappa, and delta. By combining with opioid receptors, opioids produces pain relief, and it is found entirely in the nervous system, not only in the central nervous system but also in the peripheral nervous system. Okay, based on the action on receptors, the opioids are divided into three groups: agonist, antagonist, and agonist antagonist. So agonist, antagonist, and agonist antagonist. So what is an agonist? Agonist opioid combines with opioid receptors to produce the physiological action. So what is the physiological action? It is the pain relief. And another important thing is this. Suppose this patient has a pain score of 10 by 10, and you are giving an agonist opioid. You are giving this much, so that this much pain relief the patient will get. And as you increase the dose, you will get corresponding pain relief. And when you increase the dose up to here, theoretically you will get 100% pain relief. This means agonist opioids have no ceiling effect for analgesia. Opioids have no ceiling effect for analgesia. But so many of the drugs or opioids which you know are agonist: morphine, methadone, fentanyl, all. Okay. What is an agonist antagonist? You can compare these two graphs. So the one on left side is a graph for agonist, and this is for agonist antagonist. You can see when you increase the dose of agonist antagonist, you will get a corresponding pain relief up to a point. You can see in this, up to this point, you will get corresponding pain relief. But after this, even if you increase the dose of the agonist antagonist, it is not going to give you corresponding pain relief. You can see the curve plateaus. So this is the main difference between agonist and agonist. That means agonist and agonist have ceiling effect for analgesia, whereas agonist have no ceiling effect for analgesia. Okay. So pentazocine, which you have, it is a mixed agonist antagonist. It acts on kappa receptor as an agonist. So what happens? Pentazocine is a weak antagonist at mu, whereas morphine is mu agonist. And you have to understand that the opioids which are acting on mu receptor is the potent opioid. So if you give pentazocine to a patient who is on large dose of morphine, the morphine will be displaced from the mu receptor, and instead pentazocine will attach with the mu receptor, so that action of pentazocine at mu is antagonist. So the pain relief will now only be due to kappa receptor. So actually, theoretically, if you administer morphine to this patient, in pentazocine to this patient, his pain is going to increase. So if a patient is on large dose of agonist drug, you should not administer agonist antagonist to that patient. Instead, you can whether he has missed a dose, you can ask the patient to take morphine itself or increase the dose of morphine. So we will move on to adverse effects of opioid. Adverse effects can be divided into two. One is side effect and the other one is toxic effect. Side effects means these are adverse effects with therapeutic doses. So what are the side effects? Constipation, nausea, vomiting, sleepiness and tiredness, itching, and dry mouth. Urinary hesitancy. So the first three are common adverse effect, and the last three are rare adverse effects, rare side effects. And constipation, it occurs in about 95% of patients, and it will last as long as the patient is on opioid. So you have to give a regular stimulant laxative along with the opioid. So it is stimulant laxative. Bisacodyl, senna, sodium pycosulfate. These are the examples of stimulant laxatives. Nausea and vomiting, it occurs about 3 to 5 days. After that, even if you don't give anything, it is self-limiting. So this is due to many mechanisms, but it is mainly due to stimulation of chemoreceptor triggers on in the brain. So what will you do? You have to give medications which is acting on CTZ. The examples are haloperidol, metoclopramide, and domperidone. And even 5-HT3 antagonists like ondansetron, granisetron, all can be given, but we prefer to give metoclopramide because of some reasons. Sleepiness and tiredness, again, it occurs in 1/3 of the patients, and it is self-limiting. Within 3 to 5 days or maximum of 1 week, this will be over. So you need not give anything. What are toxic effect? It is the adverse effect when the administered dose is higher than the required for pain relief, or when the patient pain has poor response to opioid. So delirium, myoclonus, drowsiness. These are the symptoms with which a patient reports to you. And if this occurs, this means that you have to reduce the dose of opioid. And all of you might be worried about this opioids producing respiratory depression. So let's see some evidences. So this is a systematic review came in 2003, which says patient takes their medications by mouth combined with normal gradual increase in dose ensures that respiratory depression is unusual. So you have to understand that respiratory depression is not very common. Actually, I haven't seen any case of respiratory depression during the last 16 years of my palliative care life. And it again went on to say that when respiratory compromise does occur, an alternative explanation should be sought, such as pneumonia, pulmonary embolism, or cardiomyopathy, or co-administration of other sedating medications such as benzodiazepines. Okay. And this is another problem for us, opiophobia, opioids causing addiction. So substance abuse as a result of medical use is low, but it can occur, but it is low. And there is a confusion between physical dependence and psychological dependence. The psychological dependence is known as addiction, and there is overestimation of risk of addiction. So let's see the definition of addiction. This is by American Academy of Pain Medicine and American Pain Society and American Society of Addiction Medicine in 2001, which says addiction is a primary chronic neurologic disease. So addiction is a disease with genetic, psychosocial and environmental factors influencing its development and manifestation. So that means it is a genetic. If you have a gene which predisposes to you for addiction, then, and if the environment is favorable, then there is a chance that you can become an addict. So some of the features of addiction are impaired control over drug use, compulsive use. You know that this is going to cause more problem to you, but still you continue to use. There will be rapid escalation of doses, and there will be frequent reports of stolen opioids, etc. So physical dependence can be there for many medications. So if a patient is on beta blocker for a long time, and if you stop it abruptly, it is going to cause withdrawal symptoms. So this can occur in case of any medications. So to reduce the physical dependence, you have to taper the dose and then stop the morphine or opioids. So this is something which you have to understand. Pharmacoeconomics, something which everybody will neglect. So if you look at, I have given the dose of various opioids which will give pain relief. These are equipotent dose. So if morphine 5 milligram 4 hourly, which will cost only 3 rupees 50 paise per day, whereas tramadol for the same pain relief will cost 24 to 50 rupees. For the same pain relief, fentanyl is going to cost 250 to 400 rupees, whereas methadone only for rupees 50 paise. So thank you. Uh, so I'm happy to answer any of your queries.
Sir, I have a question.
Yeah.
So my first question is, the oral bioavailability of morphine is 33%. So why are we not increasing once we have given the IV dose and we are giving the same dose as oral?
Yeah. This is there are reasons. First of all, I have to tell you that there is a study which has conducted by giving a rapid IV titration method, and they have converted the same dose of morphine to oral morphine. That's one thing. And another thing you have to understand is morphine, when you give intravenously, 100% is available for action. But in case of oral morphine tablet, the metabolite only 10% is 10% bypasses the liver, but the morphine 6 glucuronide which is produced is twice as potent as parent morphine. So if you continue to give orally, the M6G is the main medication or main metabolite which is going to give pain relief. It is not morphine. So it is twice as potent as morphine. That's another reason for why it is when converted from IV to orally, the same dose is administered.
Sir, one more question, sir. So can we start with the first, like after giving IV morphine, titrating IV morphine, can we start with directly with sustained release morphine?
Sorry, I didn't get the
We are giving instant release morphine for starting the treatment.
Yeah.
Especially after giving titrating with the intravenous. Can we start with sustained release morphine itself? Rather than giving 4 hourly dose, we can give 12 hourly.
but the problem is that sometimes we don't know whether the pain is stabilized at that moment. So you have stabilized the pain for that moment. Maybe after 2 or 3 days, we will better know whether this patient require a constant dose of morphine. Then you can convert it into sustained release morphine rather than converting it into sustained release morphine immediately after the morphine trial.
Sir, one more question. Sir,
Yeah.
one of the patients was complaining of nightmares after taking morphine. So she has stopped
Yeah.
taking it. Is there an
Yeah.
incidence or can we do something for it?
Yeah, definitely. And this is bad dreams because of opioids usually occurs. So what you can do is, if the patient has good pain relief and the problem is bad dreams, then a small dose of antipsychotics will help. Maybe haloperidol, 0.5 milligram or 1 milligram.
Okay, thank you, sir.
Dr. Sunil, I have a question.
Yes, please.
Dr. Sunil, the scenario that you spoke about, patient on morphine and amitriptyline with delirium, the discussion was that we will change to methadone.
Yeah.
So since the patient is already in delirium and methadone takes time to act, do we continue both morphine and methadone till the methadone kicks in, or we stop morphine and put him only on methadone?
Okay, good question, sir. If you start a patient on methadone, then you can keep the morphine as 4-hourly SOS. So suppose this patient 10 milligram 4-hourly, maybe you started him on 5 milligram methadone, then the prescription will be tab methadone 5 milligram BD, tab morphine 10 milligram Q4H SOS. Not Q4H and SOS, it will be Q4H SOS. Early, if needed, a patient can take SOS.
Okay, okay, all right. Thank you, thank you.
So we have a chat question, sir, by Zena.
Yeah.
Do you have special
Okay, let me
preparation
see.
for rectum morphine?
Okay, we don't have special preparation for morphine. We use the same immediate release morphine. Any more questions?
Sir, one last question. This
Yeah.
absorption of morphine is, like for that example, the patient who is not able to take orally,
Yeah.
is the absorption of morphine better per rectally or by the PEG tube or the Riles tube by the GI system?
Okay. So this is again a very good question, because if you look at the literature, it says oral route, morphine is directly absorbed into the venous system, rectal vein, from I think from middle rectal vein and superior rectal vein. It bypasses the liver. But for the practical purpose, we can say that oral route is as equivalent to parenteral route for all the
Dr.
practical.
Sunil, your voice is low.
Yeah, parenteral route is as equivalent to the oral route for all practical purpose.
All right. Thank you, Dr. Sunil. Thank you.
Thank you, sir. Dr. Parul have raised her hand. Dr. Parul?
Yeah.
Yeah. Hello, Sunil sir. This question is not related to this class, but in general, in the WhatsApp group, two books were shared, one by Sir Robert Troycross and one by Amar Rajagopal sir. Both related. One is the Indian context and one is the general palliative medicine. So how do you suggest, how do we read it? Like, give us some suggestions.
Sorry. I didn't hear.
No, in the WhatsApp group of this course, we have
Yeah.
two books were shared. One is by Sir Robert Twycross on palliative care, and one was the Indian context of palliative care by Rajagopal sir. So, how do you suggest? How do we read it? And yeah.
Uh,
Or this lecture, or
both
these
are
discussions are enough.
and there will be many points in both which we have not discussed. What I have done is the practical points which many doctors raise, so that I have made it like a case discussion. So I would encourage you to read both if possible, but at least one. That is your choice, Dr. Parul.
Thank you so much. Thanks.
Rajlakshmi, shall we move on to patient story?
Sure, sir. Dr. Rama, can I share the presentation?
Yeah. Good evening, everybody. Today I'll be presenting a case of a lady who's 23 years old, and she presented to the hospital with pregnancy and large bowel obstruction due to a rectal growth. She presented to the general surgery department about 2 months back with history of constipation, inability to pass. Not 2 months, maybe about 4 months back, with the history of constipation, inability to pass flatus, and since 4 to 5 days. So she had amenorrhea of 6 months with history of bleeding PR 2 to 3 episodes during this period of pregnancy, for which she took the treatment from a local doctor. Her colonoscopy was done, which revealed a large bowel obstruction due to the rectal growth. Then she was taken up for emergency laparotomy, and a diversion colostomy was performed, and at the same time a punch biopsy was done. Postoperatively, the patient tested COVID positive. She was quarantined, had some wound dehiscence, and later underwent resuturing also. The decision was made to follow the CA rectum protocol after the delivery. The patient developed abdominal pain of moderate to severe intensity, along with the pain in which which was severe in nature and was pricking and throbbing type. She was treated by the surgeons in the ward with intravenous tramadol and paracetamol. She was referred to the palliative pain clinic after 6 weeks of all this, when her pain continued to remain of severe nature despite the above treatment. On examination, she was a thin-built lady of adequate nutrition. She had a colostomy bag, and there was some wound dehiscence in the upper end of the laparotomy wound, but there was no growth outside in the perianal area. The problems encountered at this time seemed physical, that is her pain, then emotional component because of her pregnancy, and psychosocial because of her colostomy wound. She was started with WHO step 3 ladder treatment with tablet Rantac 150 milligram BD, tablet morphine 2.5 milligram TDS initially, which was increased to 4 hourly after stopping the tramadol. PCM was given 650 milligram QID, and SITS bath was advised for local pain along with xylocaine jelly 2% locally, SOS. She was also advised to take immediate release morphine for any breakthrough pain if she suffered. It was difficult to convince the obstetricians and the surgeons for her morphine, as they were scared of the fetal well-being. So patient was counseled for being extra vigilant and report any decrease of the fetal movements immediately. The pregnancy was continued till 33 weeks with strict vigilance. Patient was taken up for cesarean section at 33 weeks after a dose of dexamethasone 6 milligram 2 days prior to the cesarean when it was undertaken. Oral morphine was stopped the night prior to the surgery, and naloxone was arranged for the baby. A 1.9 kg female child was delivered. The surgery was undertaken under combined spinal epidural anesthesia. This epidural catheter was maintained for pain for 72 hours, and no morphine tablet was given during this time, but NSAIDs were continued. So the psychosocial aspects were there, that it was a pregnancy with a major malignancy. The issue was to look after a small baby, and she also had a 3-year-old child earlier. And to look after the old in-laws, the social stigma of the colostomy, and poor socioeconomic background. The medications that the patient received when she was discharged post LSCS, she was happy to have a healthy baby, and she was put on pre-cesarean morphine doses, that is 2.5 milligram 4th hourly, but she needed it to be increased to 5 milligram 4 hourly, and also advised to take any more for breakthrough pain. Along with this, paracetamol was administered 500 milligram QID and Voveron SOS. Then oncoradiology department was consulted for her further management, and neoadjuvant therapy was advised for further treatment. She received the first dose of chemotherapy within a month of her recovering from the cesarean section. Then her husband used to come for the medication to the hospital because she used to find it difficult to come with a small baby. Subsequently, her morphine dosage had to be increased to 10 milligram 4th hourly along with adjuvants. Presently, she has completed her radiotherapy, and the third dose of chemotherapy was scheduled for 24th December, which she has already taken. She has mild bleeding PR, which the radiotherapist says is due to sloughing. She would be undergoing surgery in January after this. So main concerns were pregnancy with malignancy, concomitant chemotherapy, titration of opioids and NSAIDs, postoperative management and management of complications, and management of newborn and feeding. So in summary, she is a young pregnant patient with a 3-year-old child through a cesarean section previously, and another child through this cesarean section, along with a colostomy with pain in the local area as well as abdominally, chemotherapy, radiotherapy, multiple surgeries. The psychological are, though she is a calm person, she has accepted the situation and has siblings and in-laws who are supporting her. Her sister has been the caregiver in the hospital along with her husband. Now she has sent her younger child to the mother-in-law, to her mother, as the mother-in-law is not well. She cannot handle the younger one as her hands tremble post chemotherapy. Financially, she is of low socioeconomic status, but most of the treatment has been free. The discussion points in this are a complicated pregnancy, invasive management, role of analgesics, psychological problems, low socioeconomic background, the role of caregiver, and management of the newborn. Then and also what would be her subsequent management and future course of her treatment life. Thank you.
Thank you, madam. So this is a very interesting patient story, and which we usually don't come across. Uh, anybody who wants to have their comments on this? Anybody?
Basically, currently her role of analgesics will have to take into account the newborn also. So she needs to stop breastfeeding because most of these drugs will get secreted
No,
in that
sorry,
and that will cause respiratory depression.
I think it can be an issue in most of the pregnancies, but this patient surprisingly did not lactate in her previous pregnancy also and in this pregnancy. So the child was never breastfed. So we did not have that issue of, giving morphine to her post-operatively for pain relief. So she has been taking morphine continuously and the child has been put on top feeds right from the beginning.
Okay. So, madam, how long this
Other
patient
thing which
was
I'm
on
thinking
morphine?
is this role of
Pardon, I could not hear.
How long this patient was on morphine during her pregnancy?
She is still on morphine. Even today, I think I heard from my colleague that she came to the palliative pain clinic and she is now controlled on 60 milligram control release tablet or sustained release tablet BD along with amitriptyline and gabapentin. 25 milligram HS of amitriptyline and gabapentin 300 milligram BD.
Yeah. When she was put on morphine, during which trimester of pregnancy?
She came to the hospital in 6th month of pregnancy. She was already 24 to 26 weeks pregnant when she presented with this obstruction, the large bowel obstruction, when the laparotomy was done. So after 1 month of that, she was put on morphine. And she remained on morphine for about 3 weeks before the cesarean section. And then she has been continuously on morphine post cesarean also.
Okay. Yeah, Dr. Gopal.
Yeah, madam, just wanted to ask a question. A 23-year-old lady having a CA is something really, really tragic. So,
Yeah.
any role for the social service and the counseling service to help her to improve her quality of life and things like that?
Presently, I think her family support is quite good. Her husband is very caring, and her even her parents and brothers, siblings are also caring. So she has good support from them, and her mother and mother-in-law are helping her in taking care of the children.
Okay, thank you.
Okay, I see there is a question from Dr. Neena. Any discussion on her survival done with her?
Dr. Sunil, your voice were very low.
Any discussion on her survival done with her from by Dr. Neena?
I could not get the question.
So Dr. Neena has asked a question. Is there any discussion on her survival?
Actually, I am not dealing with the patient directly because I have taken this case from my colleagues who are looking at the pain clinic. So I have not gone into it. Sorry, I'm not able to answer whether they have done it or not.
Okay, okay. So there is another comment from Dr. Navish. Family counseling is recommended. Pain of not being able to see her child grow up is unimaginable for any mother. Professional counseling by MSW would be good. Okay, I think the role of analgesics. What analgesics can be given in? Are there any obstetricians here? Nobody? Okay, the analgesics which can be given in each trimester, it varies. But before that, I would like to comment on the feeding and opioids, because opioids can be there in the breast milk. But from what I have read, I think that even though it is present in the breast milk, it will not amount to any problems for the child. That's what I have read about breastfeeding and opioids. But in case of analgesics, if you give NSAIDs during the first risk of miscarriage, and it is more with I think indomethacin and diclofenac. Uh, and if you use high dose aspirin, it is also a problem. But low dose aspirin is safe. Then during the third trimester also, usually NSAIDs are not indicated because of early closure of patent ductus arteriosus. But otherwise, opioids can be given if the patient has severe pain. And non-pharmacological management is something which we can try in every trimester. Uh, Paracetamol can also be used across the trimesters. Um, but if you take the adjuvants, sodium valproate and carbamazepine should not be used. But gabapentin can be used. Pregabalin again cannot be used. Then tricyclic antidepressants, sertraline or SNRIs can be used. All these recommendations are based on low quality evidence, because there are no much literature regarding the analgesic use in pregnancy. I will send you an article from 2019 on the analgesic use in pregnancy. And another important thing which you should be careful is, if you have given opioids for the pregnant lady, then everybody will be having fear about respiratory depression of the child. But more than that, we should be looking for a neonatal abstinence syndrome if the mother was on long-term opioid, because once the baby is out the uterus, there will be withdrawal symptom in baby, which is known as neonatal abstinence syndrome. So that has to be managed properly.
We have abstinence syndrome after how long of opioid use in neonate?
Actually, if you have given opioids like morphine, the abstinence syndrome will start by 24 hours. So you have to substitute with morphine, and then gradually taper the dose and stop. If the patient is on methadone, it will take more than that, maybe 72 hours to have abstinence syndrome. So the most important thing is, we have to be aware of this abstinence syndrome. Then only we will look for it, and then only we can manage it.
How does it manifest in a neonate, the abstinence syndrome?
Okay, so there are various manifestations, but most importantly, sleep and wake cycle disturbances. Usually it is presented as fragmented sleep with short sleep cycles, and difficulty in maintaining the alert state. There will be alterations in the tone or movement, which can be manifested as hypertonicity, tremors, etc. And autonomic dysfunctions can be there, like sweating, sneezing, fever, nasal congestion, frequent yawning. And then patient will be very much irritable. uh, they can have vomiting, diarrhea. These are the usual manifestations.
Thank you, Professor.
Mostly in newborns with opioid withdrawal, they'll present with seizures, madam. Undiagnosed seizures would be one of the presenting features in that. So we need to think of that. Respiratory depression.
Thank you, Dr. Mahavish.
Okay.
Sir, we'd like to know
So,
what is the future course planned for this patient. What are the treating doctors? What have they decided? What is the plan for this particular patient? Dr. Rama, can you please share that?
She has, as I said, that she has undergone the third dose of chemotherapy and finished her radiotherapy sittings prior to surgery. So today she has undergone a CT, and the report of that is awaited, after which they will decide for surgery. And then it will be followed by further doses of chemotherapy, 3 more doses. 3 she has received before, 3 she will be receiving after the surgery. In January, most likely in first week of January, if her CT does not show much of involvement and it is a resectable thing, then she will be undergoing surgery.
Dr. Sunil, can you share what is the social support mechanisms available across the country for this? See, we are aware of some private organizations like cancer group and all coming and helping them. But do we have any formal mechanism to tap the social support for such patients? Because some question like that came.
I don't think there is no such groups available. I think it is our responsibility to make such groups. Each institution or those who are treating not only for palliative care patients or any patients, this social support mechanism is something which is necessary. So it would be our responsibility to make it.
Thank you.
Sir, my question was coccygeal nerve block can be given?
Dr. Namrata?
Yes, sir.
Yeah.
I think
We didn't
coccygeal
hear.
nerve block can only be given if she is not controlled with morphine. Presently, she is well controlled with this 60 milligram video of sustained release morphine. But if she if she is not controlled on further doses, then of course ganglion impart block or something can be given.
I'm asking during her pregnancy time to prevent giving morphine.
She had abdominal pain also, besides the perianal pain.
Oh, okay, ma'am. Sir, Dr. Sunil, I have a question not related to the case presentation. If the patient is having on the morphine, if the patient is having severe constipation, should we stop the morphine?
Okay, this is probably if we manage constipation, try to manage with all the laxatives available. Usually with the bisacodyl and another osmotic laxative like lactulose, it should be manageable. But if not, you can try polyethylene glycol. PEG is available as sachet. So that can also be tried, and if not still constipation is the main problem, then you may try to change over to another opioid. Sometime that will help.
Also, I would like to say for that ganglion impart block during pregnancy, the baby is there inside, and probably it would be dangerous, to give that block at that time. With the soft ligaments and no perception, you can damage easily.
Yeah. So any more comments or questions? No questions. I think we can wind up the session, but I think this patient story was little bit different, and which we usually don't come across, but it is good to stimulate our thoughts, and thank you for all of